The views expressed on the following program are designed to amplify those of the speaker and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.
It is time to Ask the Pros, the only live local interactive radio program that addresses home, health, and wealth matters Monday through Friday. A program hosted by arguably the most knowledgeable and reputable authorities in their respective industries, affording you the rare opportunity to ask them any questions related to their field of expertise for free. Just pick up the phone and call KAAM right now to Ask the Pro. Now, here's Dr. Birnbaum.
Good afternoon, everybody. This is Dr. Dennis Birnbaum. This is Cancer Update, a short walk through a long journey. The number here at KAAM 770 AM on your dial is 972-445-0770, and the toll-free number is 877-272-5226. I am anxiously waiting for a call today from our guests who we're going to have on the show today, Dr. Richard Bush, B-U-C-H. I've known Dr. Bush for many years. He is an outstanding individual in the field of surgical oncology, but especially in the field of surgical orthopedic oncology. Dr. Bush did his training at Indiana University School of Medicine, residency also at Indiana University School of Medicine, Department of Orthopedic Surgery, and a fellowship in orthopedic oncology, which is very rare. Very few orthopedic surgeons do that extra time just to learn about orthopedic oncology, cancer that has affected the bones. He did that at George Washington University Medical Center, the Washington Hospital Center. Dr. Bush is a fellow of the American Academy of Orthopedic Surgeons, diplomat of the American Board of Orthopedic Surgeons, member of the Dallas County Medical Society, the Musculoskeletal Tumor Society. He is on staff at Medical City Dallas Hospital, Centennial Medical Center, where he was the past chairman of the Department of Surgery and chairman of the Department of Orthopedics. He's also on staff at Medical Center of Plano, Pine Creek Hospital, and Dallas Medical Center at 635 at Webb's Chapel. We will be waiting for Dr. Bush to call in. This is Breast Cancer Month. You see everybody wearing pink, from the NFL to the basketball to the baseball World Series. Everybody is wearing pink. I hope you have observed this. We recently had the Komen walk here in Dallas. It was tremendously beneficial, raised an enormous amount of money. In the forthcoming months, we will have special prostate cancer month, lung cancer month, and I hope each and every one of you will pick out something to participate in, to join in, to be a part of. It is extremely heartwarming and worthwhile, and coming very soon, there will be many hospitals and cancer centers. Our practice will be doing a special screening for prostate cancer, probably starting in the month of November, with free PSA and examinations. I think these are important. Remember, early detection is the key to cancer treatment. The earlier you can find the disease, if it's going to be there, the easier it is to treat, and the longer the survival and the better the quality of life. Also, there are many churches, hospitals, businesses that have support groups. Participate. If you have a friend or a family member that, God forbid, has cancer, go with them to the support group. Help them out. Be part of their life. It is very self-rewarding. It is an enormous experience. And if you've got a personal family member that has cancer, don't shy away. Be part of their life. Help them out. You can never tell when, God forbid it, you may become afflicted with this same type of illness. In today's society, cancer is not what it was 20, 30 years ago. The word is not as frightening as it used to be. The treatments are not as devastating as they used to be. The advances in the use of concomitant, meaning joining with chemotherapy and radiation therapy, is much easier to take today than it did 10, 15, 20 years ago. The big C does not have the frightening connotation that it did many years ago. So work with your friends or your family members that may have cancer and be a part of their life, and don't shy away from it. There was a recent article that came out that was in the journal, the ASCO Post, American Society of Clinical Oncology, that talked about starting over after cancer treatment. Patient's name was Paula. She stated that her cancer was incurable. She said she probably knew the additional therapy was going to be necessary. The thought of having to once again navigate through a complicated healthcare system, as well as deal with physicians who are not always helpful, became daunting. She emphasizes how important it is to work with a doctor who is interested in your care. She says that she eventually switched over. It wasn't until she reached the third oncologist that she became comfortable. She knew it was going to be a long journey. And it just goes to show you that you may find that your first or even your second opinion is not always the best opinion. It's not always the doctor who comes up with a new protocol. It's the doctor who will sit there and take the time to talk with you, to discuss your problems, and to be available to you. We have with us right now Dr. Richard Bush. Good afternoon, Richard. How are you?
Hello, Dennis. How are you?
I'm doing fine. I've already introduced everybody to you and told them where you did your training and where you're from. I'd like you to, I'm going to have some questions for you, but explain to the audience, Richard, what is the difference? We all go to an orthopedic surgeon. We have a broken leg or a broken arm, and we go to an orthopod, and he sets our arm. What makes you, even though you do those things, what makes you different? Why is an orthopedic oncologist so different than the average everyday orthopedic surgeon?
Okay, what it actually started from is in the old days, there was a bunch of people that had cancers of bone that back then when they made diagnoses, and you're talking 30 and 40 years ago, that nobody knew anything what to do with them. Most of the things we knew about those kind of things were from general surgeons and so forth. There was nobody that was specializing in just tumors of bone and muscles and so forth. And then as time went by, we started seeing more and more of these people because they were breaking bones from tumors and so forth. And then the discipline of orthopedic oncology started with about 2 or 3 people in the United States. One of them was in Florida, one was in Boston, and one in Sloan Kettering in New York. That's where the big 3 started, and the whole system of orthopedic oncology started. When I first started, there were maybe only 30 or 40 people in the United States that did this kind of thing. And we've trained people now over the last 15, 20 years in the discipline of orthopedic oncology. And what it involves is tumors that are related to the bone, whether it be in kids or adults, and soft tissue tumors of the muscle or fat cells or nerves that we've now seen over time. And it's very specialized. There's really only about 110, 120 of us that do this all the time in the United States.
Explain the difference in those patients who are a primary bone tumor as opposed to those who have metastatic, let's say from a lung cancer or colon cancer that go to the bone. What is your position and how do you get involved in either case, whether it be a primary or a metastatic bone lesion?
Correct. A primary bone lesion, when they say primary, means there are tumors or cancers that start directly in the bone. most of the tumors, all right, and a tumor is an abnormal growth. For the audience, people understand a wart is a tumor, all right, but it's not a cancer. Okay? Well, the same type thing happens inside the bone. Most lesions in the bone are benign, but there are some that are cancers. Most cancers that occur in a bone usually are fast-growing or are painful, and they start in the bone, and then they can go elsewhere in your body. Most of the people, as we get older, have a cancer in the lung or their pancreas or the kidney, and then gets from there into the bone, and then it becomes something called metastatic. We see both types of patients. We cannot see all metastatic disease because there's so many people that are in small communities that break bone for metastatic disease that a lot of them are taken care of either by general surgeons or orthopedic surgeons. But the ones that become very complicated or require special needs, those kind of ones we see, especially the ones that have a primary bone tumor, because most people don't know how to take care of that. Once you have cancer of the bone or metastatic disease, there are some people that you're just trying to fix the bone so the patient can get on with their life.
We have with us today Dr. Richard Bush, who is an orthopedic surgeon and a subspecialist in orthopedic oncology. His phone number is 469-443-0924. He is located in Plano, Texas at 4001 West 15th Street in Plano, Texas. And as I mentioned to you before, he is a fellow of the American Academy of Orthopedic Surgeons and a diplomat of the American Board of Orthopedic Surgeons. Richard, let me ask you, in your experience, what is your delay time? We hear about somebody needs to get radiation therapy to the bone before they're sent to you. Do you prefer to do your manipulation or your surgery first? Or in some instances, do they do the radiation first, and what is the time lag? I've talked to other surgical oncologists, like for rectal cancer, where we give pre-op chemo and radiation, then we take them to surgery. How much time and what is the difficulty that you have in radiating bone in relationship to radiation therapy?
That's a very good question, because this is the argument we have all the time, even in our own societies. The problem is that there are different presentations. It would be best if once they have metastatic disease, for us to evaluate them first, because there are some that need to be treated first before doing radiation. There's a reason for that, because if it's a lesion on the bone and it's weakened the bone enough by the time you see them, right, or you got a big hole in the bone, those are best treated first with surgical treatment before they break and then do radiation. The reason for that is that it takes a while for the radiation to kill the tumor, but everybody forgets that it takes a longer time for the bone to heal over an area that the bone has been destroyed on. And so it's usually the risk of fracturing during that time is way too high for them to not be treated first. There's a thing called prophylactic treatment, which is much easier to treat. It's quick, it's easy, they stand, they go right away, and then they can have radiation. The other reason sometimes is that once you do radiation, if you then have to operate, your risk of wound problems and infections is higher. And so it really needs to be evaluated by somebody who knows what they're doing first to see if it needs to be treated first before you do radiation. Now, my biggest problem is a lot of people come in and have huge lesions that probably should have been treated first, and now it's more difficult to treat after the fact. They all need radiation. Almost all metastatic disease, when they get to large enough going to break the bone, probably need radiation and or chemotherapy. But a lot of them probably need to be treated first, and it's much easier to treat it before they have radiation.
In your experience, I know I see a lot of patients that come to me with metastatic disease to the bone, and a lot of the metastases or the spread is to weight-bearing areas. What is your philosophy with regard to approaching those patients who have metastatic disease to weight-bearing areas? Some doctors feel, who are in the non-oncologic field, wait till something happens. I prefer myself, and I may be obviously a little bit more proactive and aggressive, that these should be given attention immediately in order to prevent any type of fracture. As an orthopedic oncologist, and you have a patient that has extensive metastatic disease to weight-bearing areas, obviously the lower extremities and the hip area, how do you approach these patients?
Yeah, we have the statistics on that there's two things. First of all, just go anybody over the age of 65 that breaks their hip. Everybody forgets that a number of those people do not make it out of a hospital. You can die from a simple hip fracture without metastatic disease. Now magnify that with somebody who already has cancer and then breaks the bone, okay? They're 3 to 4 times more likely than a person who broke a hip of not making it out of the hospital. And because once you break a bone, it releases a whole bunch of what we call evil humors, that fat cells and tissue cells, and some of that cancer that can get through your bloodstream and causes a whole bunch of hemodynamical problems with the body. If you fix it before it does that, they can sit there and make it through the surgery much easier and much quicker. And that's why when you got weight-bearing bones, it's better to fix them before they break. The problem is that a lot of the guys will wait till they see a cancer. The problem is that once you see it on a bone and you can see a dark area on the bone, that means half the bone's gone. So it's already weakened half the point, right? If you can recognize it as a regular person, not an orthopedic surgeon. So once you see a big lesion in a bone, it's best to fix it and then treat it.
We have with us Dr. Richard Buch. That's B-U-C-H. His office number is 469-443-0924. He's a member of the staff at Centennial Medical Center, Medical City, Dallas, Medical Center of Plano, Pine Creek, and Dallas Medical Center. Richard, define for the audience vertebroplasty and kyphoplasty, and how does it apply in orthopedic oncology?
The most common place for metastatic disease is the spine. When it occurs in the spine, especially in your building blocks or your vertebral bodies, again, when it gets in there, it weakens them and then you can get fractures. In the old days, we didn't treat them because it was too difficult. We had nothing to do. We'd go in there and have to operate and do big spine surgeries. That's a big, giant surgery. In this day and age, we can stick a needle into the bone, even with metastatic disease, and you can inject it with things that stabilize the bone, and basically it's a cement, and that's what a vertebroplasty is. A kyphoplasty is you're putting a balloon in, blowing it up, trying to increase the width of your bone and back to where it was before it collapsed, and then injecting with cement. So they're really the same type things, but they're both there to stabilize your bone. And also your pain comes from the collapse and the nerves around that. Once you stabilize it, a lot of their pain will go away. So it's excellent for pain control. And everybody forgets, it's not just cancer. And you see it too, there's people with severe osteoporosis that by the time they come to you, people think it's metastatic disease, and it turns out to just be osteoporosis. And that's another treatment option for them for the same reason. It helps them with their back and stabilizes their spine without surgery.
Let me ask you, I recently had a patient, and I don't want to step on anybody's toes, whether it be orthopedics or neurosurgeon. If you have a patient that you're concerned about cord compression from a vertebral body onto the spinal cord, is this an area for a neurosurgeon, or is this an area for an orthopedic surgeon?
That's a very good question. From an orthopedic spine surgeon is very good at instrumentation and taking care of scoliosis and things like that. There are some trained more around the nerves and decompression, and they can do that. But neurosurgeons are trained a little bit more around nerves and things. And so to do that, there is a slight difference between them. They really do cross over and do pretty much the same things. But to deal with nerves, neurosurgeons usually do a little bit better job, especially in the cervical spine areas, than do orthopedic surgeons. When it's on the lower back, either one can sit there and take care of it.
In today's modern oncology, when I was back at MD Anderson, and the big name in sarcoma was Bob Benjamin. Virtually everything back in the pre-Civil War days was leading to amputation. When you have somebody with a limb sarcoma or with a malignant fibrohistiocytoma of an extremity, is the treatment today geared at surgical treatment, or is it towards amputation?
Okay. In this day and age, and the most important thing is early diagnosis. You kind of mentioned that already. Even in my discipline, if you catch it early enough, almost all the time we can save your limb. And that always requires a surgery in any malignancy. And the combination is a team of physicians, the radiation oncologists, you, the surgeons and therapists, and a whole team that takes care of them in a staged type protocol. And so the kind of cancers that you're talking about that are big malignancies, the best thing to do is to treat them first and shrink it, operate and get rid of it. And the reason we do that is twofold, is that by the time they come to us, sometimes it's always a little late. You know that by the time they finally recognize it. It's best to give chemo up front because you want to see if it's going to be effective, and you want to kill it anyplace else. And then once you see that happening, you take it out and see if the chemotherapy you've been giving is working. And if it is, then you continue with it. If it's not, then you'll probably change your protocol, and the patient has a better chance of living, and they finish their chemo after. That is the most common thing that is done. In the old days, we used to try to treat them first and then give chemotherapy, and vice versa. And it doesn't work out the best that way. It's best to do a staged-type procedure because you have your best chance of recovery by all the studies by far in the United States.
We've talked about radiation therapy and how it applies to orthopedic surgery and how much delay in time that you can operate after somebody's had radiation. Is there the same delay in somebody that undergoes neoadjuvant chemotherapy? Do you have to wait as long to go ahead and do any type of operative procedure?
There is a slight delay because when when you get chemotherapy, chemotherapy doesn't just kill tumor cells. It also kills some normal cells in your body. So your blood cells and things, your body has to recover a little bit. It usually takes about 2 weeks or so, and then once you hit that point, then you can have surgery. The problem with radiation is that it takes a little longer for the tissues to recover with radiation, so you usually have to wait 6 to 8 weeks or at least 2 to 3 months before you operate. So there's that delay in that kind of treatment. So in chemotherapy, you can go quicker. Radiation, you have to wait a little longer.
In your experience, we hear about this, and I'm always called in as a consultant in working on somebody for anticoagulation therapy, not only in the field of orthopedic oncology, but in orthopedic surgery itself, broken hips, etc. What is your incidence of these patients developing deep vein thrombosis and blood clots?
If from an orthopedic standpoint, let's say somebody had a total hip replacement, the risk of developing a blood clot, right, can be as high as 40 or 50%. They get blood clots, but they don't get blood clots that go from there into their lungs. All right, so the misnomer is that you're going to prevent all blood clots. Not true. There will be blood clots after surgeries. What you're trying to do is prevent it from becoming a problem. If you get treated appropriately, anybody that has a hip or a knee or a big procedure needs to be anticoagulated within 24 hours after surgery. If you do that, your risk of developing a severe blood clot or a pulmonary embolus, that's when the blood clot breaks off and goes to your lung, is less than 1%.
Is it as common in knee repairs, knee surgery, as it is in hip surgery?
It's a little less common, but you still can get blood clots around the leg and up. But the symptomatic ones that you worry about occur a little bit more in the hip.
In your practice, Richard, would you say 80% of your practice is orthopedic oncology? Or what, better yet, the better question is, what percentage of your practice, seeing that you're a rarity and that you have had a special fellowship in orthopedic oncology, but you also do basic orthopedic surgery as well, am I right?
Yes.
What percentage of your practice is geared to orthopedics versus orthopedic oncology?
The orthopedic oncology has expanded to the point that these major reconstructions that occur for anything from infections, loss of bone from major trauma, all blend in with orthopedic oncology, because we were the first to take massive bone out and reconstruct it. So when the time comes for these infections now and things, most of them are taken care of by people who had some orthopedic oncology training. So about 60%, 70% of my practice is geared towards tumors, major loss of bone, and infections. And then the other part is just regular orthopedics or regular patients with revisions in knee and hips.
To the audience, we're being joined today by Dr. Richard Bush. He is an orthopedic surgeon with a subspecialty in orthopedic oncology, trained at George Washington University Medical Center. He's a fellow of the American Academy of Orthopedic Surgeons and a diplomat of the American Board of Orthopedic Surgeons, as well as the Musculoskeletal Tumor Society. Dr. Bush is on staff at Centennial Medical Center, Medical Center of Plano, Medical City Dallas Hospital, Pine Creek, and Dallas Medical Center. His office number is 469-443-0924. We're going to take a short break and come back and talk to Dr. Bush some more. This is Cancer Update, a short walk through a long journey. The number here is 972-445-0770. Please come back in about 60 seconds.
Rosalind Slaughter is a very busy wife, mother, and teacher. She didn't have time for cancer.
After my first diagnosis, I had 2 lumpectomies, but the cancer had already spread. The doctor gave me little hope for recovery. That's when I called Texas Hematology Oncology for a second opinion. It had become stage 4 breast cancer.
The physicians and staff at Texas Hematology Oncology Centers aggressively attacked her cancer and were concerned about her quality of life during her treatment. Rosalind has been cancer-free for over 8 years now.
It really makes a difference who you choose for cancer treatment.
Rosalind and others have turned to the cancer treatment offered by Texas Hematology Oncology Centers. Perhaps you should too. Texas Hematology Oncology Centers has offices that are located in Dallas, Carrollton, and McKinney. To call for an appointment, please call 469-453-5500. That's 469-453-5500.
Good afternoon, everybody. This is Cancer Update, a short walk through a long journey. The phone number here at KAAM 770 on your AM dial is 972-445-0770. The toll-free number is 877-272-5226. I'm honored today that we have Dr. Richard Bush joining us. Dr. Bush is an orthopedic surgeon with a subspecialty in orthopedic oncology. I've had the pleasure of having worked with Dr. Bush for many years, and I can call him my friend. He takes excellent care of my patients. He's very attentive. Dr. Bush's office number is 469-443-0924. Richard, let me ask you, going on with our discussion, we have a lot of screening that goes on in the United States. Prostate screening. Right now, we're in the month of breast cancer screening. We have the mammograms. Everybody gets their pap smears. Men get their PSA tests. Unfortunately, we don't have those type of guidelines in orthopedics and people who develop primary bone cancers. What do you recommend to tell the audience that they should do and be aware of? Because as it is in breast cancer and in any other type of cancers that we see a lot of, early detection leads to early treatment, leads to long-term survival and better quality of life. Talk to me about primary bone tumors and what prevention people should be aware of in order to get early detection.
Okay, this would be a twofold because there's a difference between soft tissue ones and bone ones. All all bad bone tumors will usually present with bone pain. So if you go see somebody and you're having pain and they're treating you, but you're not getting better within a reasonable time, right, then they have to make sure they get x-rays or an MRI or things of that nature that can tell early detection. Half the patients I see today, because of the nature of the medical business and insurances, and they have to go here and there first, are delayed treatment. And they've had pain unexplained for a period of time, almost always. And then they finally get an x-ray or finally get a scan, and then you see the lesion, and then it becomes much more difficult to treat than it does later. A perfect example is there's a young man that we had that had knee pain. He was playing football. They treated him. He kept having knee pain. He never got better. And then they finally got an x-ray 8 weeks later, and then they see a lesion in his knee. And now you wasted 8 weeks of time that you probably could have picked that up earlier. So I tell people, if they're not better within a reasonable period of time, and if someone's treating you, you're not better within a week or two, then it may have to be investigated. If you're definitely not better within 6 weeks, you might have to check some things. There's something there that's being missed sometimes. And it's better safe than sorry when it comes to this, because early detection is so important in these tumors. We can save you in a lot of these tumors where in the past, if you had a tumor, you would die. In this day and age, we can save 70, 80, 90% of people if we can detect it early. That's bone tumors. From a standpoint of soft tissue, that's much more difficult. And anybody that has a lump or a bump that's increasing in size, that's over 5 centimeters. So most people put your 2 fingers or 3 fingers together, and if you got a lump bigger than that in things, it has to be looked at. Because then, all of a sudden, if you plot these out, as things start getting bigger, your risk of having something is increased. And they're so easily taken care of before they become a problem that it goes without mentioning. And we have people come in with huge lesions in their leg and finally went to the doctor. And nothing is good. It gets better. If something's increasing in size and is large, you better have it checked. And you can still save things. We've saved some large things, but there's some people wait so long because they're busy and busy lifestyles, then all of a sudden, then you're talking about the A word, which is amputation.
One of the things that we have discussed over the 15 months we've been on radio is that you may find that your second or your third opinion should have been your first opinion. And I've found over the years that people they go to a doctor and for some reason they don't switch and their symptoms stay the same. They don't get any better. He keeps putting them either on some antibiotic or some analgesic. You recommend that if things aren't getting better and their signs and their symptoms aren't getting better, then they should take it upon themselves to either get another opinion, but to do something about it.
Absolutely. There is nothing that we can't treat in this day and age within a reasonable period of time. So I tell people especially, listen, it's okay to sit there and let them try a second time and do things. But if you're not getting better within a 6 to 8 week period of time, there's probably time to talk to someone else and make sure things, because you're right. God bless them. I mean, you can't know everything, and you go to your family practice doctors and internists who are wonderful for the most part, but they can't know everything, and they're geared to treat your symptoms, and they try to do the best they can, but sometimes they just can't. And if you're not getting better, then you need to go and either push them to get further treatment or looking at something or get another opinion. You're told every day in your magazines and your medical shows, don't be afraid to get a second opinion, right? Because you sometimes miss things. And Dennis knows, and I know, we've been doing this a long time, that we're not completely always right. And we may be the smartest guys in the world, but I still send people for a second opinion if I can't figure something out, because maybe I'm missing something after all these years. I never worry about that, telling that to a patient if I can't figure it out.
We're joined today by Dr. Richard Bush. His office number is 469-443-0924. He's located at 4001 West 15th Street in Plano, Texas. Dr. Bush is on staff at Centennial Medical Center, Medical City Dallas Hospital, Medical Center of Plano, Dallas Medical Center, and Pine Creek. You mentioned a word, Richard, soft tissue sarcoma or soft tissue tumors. Explain what that is and how that is different than other types of orthopedic tumors.
They're different because they involve your soft tissues. Anything in your body, any tissue can turn malignant. All right, so you can have malignancies of the blood cells, that's leukemias. You can have malignancies of the bone, which is osteosarcomas or malignant fibrocystomas. The muscles are prone to get soft tissue sarcomas. And your nerves can get nerve tumors called schwannomas or normal fibromas. So any tissue in your body can become malignant. The problem with the soft tissue ones, there's not a lot of nerves in your soft tissues or in your muscles. And the problem is they can get to large sizes before they're recognized. And so they're much more difficult. So that's why I tell people, if you got a lesion and it's fairly big or it's bigger than it should be, and it's definitely increasing in size, that needs to be looked at because that's a sign that something's could be wrong. And they're just harder to diagnose. And so we have talks at every orthopedic academy about, and it's called lumps and bumps, and trying to teach the guys when to worry about, because we have to even teach the regular orthopedic surgeons what to watch out for and not watch out for. And they're very difficult. So the best thing is, if you got a large lesion, it needs to be seen or evaluated. And if you got one that's definitely increasing in size, it needs to be evaluated. Because you may not have any pain. It just may be size.
What is your criteria when it becomes necessary for amputation?
Okay. If the tumor is so far involved and it's outside of a compartment. So let's say your thigh, for instance. Okay, your thigh has a compartment on top of your leg, and the back of your leg has a separate compartment. If your tumor has been there a long time and it's wrapped around your nerves and vessels, and it's highly malignant, to save your life, all right, you can't just strip it off the nerves and vessels. You leave tissue behind, and it'll come back. And even chemotherapy can't kill it all. So there's some circumstances, if you wait too long, we can't save the leg, and you have to do an amputation. That's why early detection is important, because they rarely get involved in those areas until they're so big. They usually grow in the tissue, and they will grow from inside out. So they always push things away until they start abutting things. And then when they start abutting things and they get too large, then they will start invading into other tissue, and then sometimes it's too late.
Do these people, after the amputation, undergo either radiation, chemotherapy, or both?
They can be both, because it depends on the diagnosis. Everybody needs to understand there's so many different types of cancers, and they can all be treated somewhat differently. But the majority of bad malignancies require a combination of therapies.
How long after the surgery and or the treatment is the patient then set up for a prosthetic?
Okay, if they have an amputation, okay, as soon as the wound heals and it's stable enough, they can then be fitted for temporaries or what's called stump shrinkers to get them ready for a permanent prosthesis. In this day and age, most people are put in temporaries until their leg gets used to it and accommodates, and then they're put into a prosthesis. So they always have a temporary, which isn't look like a normal leg. It may just be metal that you walk around with for a while until you get used to it, because your leg and your let's say you have what's called a below knee amputation, and what we call your residual limb is sensitive, and it takes time to get used to fitting into something. Just like a new pair of shoes, you have to break them in, you have to break the prosthesis in before you fit with a permanent one. That's usually 6 to 8 weeks after surgery.
Anybody in the audience that wants to call in for any questions, they can call in at 972-445-0770 for any questions for Dr. Bush or myself. Dr. Bush's office number is 469 443-0924. Richard, in your experience, and what is the realm of orthopedic oncology that you see are handled? Is it usually limbs, spine? Exactly what is the wide array of types of tumors that you deal with?
The most common areas that the tumors occur is around the spine, pelvis, and the lower extremities. You'll see it sometimes in the shoulders, but a little less. So the most common places really is your torso, which is your lower spine, and then your pelvis, and in your hips and femur areas, and close to your knee. Those are the most common bone tumors and things, and soft tissue tumors. That's where they mostly occur. And and those areas, for at least for soft tissue, are harder because if you got a tumor that's in your leg, it can grow to a pretty big size before you even recognize it. So, but those are the most common areas you see what we see. But you can see it in any bone or any tissue anywhere in the body.
In oncology and medical oncology, especially in breast cancer, we have trauma tumorigenesis. Women who they're in a wreck and unfortunately their breasts get smashed against the steering wheel and they develop trauma to their breasts, and we find a year or two later that same area has developed into a cancer. Do you ever see people who have had hip damage or leg damage, orthopedic damage, who later develop tumor in those sites as a secondary from trauma tumorigenesis?
No, absolutely. And you see this especially in soft tissue sarcomas. And what we think is happening is everybody in life probably has the capability of getting a cancer. But if the right things happen in life, the right trauma or incident or something happens, it can key your gene into growing. And one of the common things we see is someone will have an injury or got hit somewhere, and they get a bruising. And then there's a knot there, okay? And the knot should go away because they're treating it as a hematoma. But lo and behold, that knot's still there 2 months later, and all of a sudden that knot's getting bigger. You got to start worrying. And one of the things that we miss all the time, and the common things I see from general surgery, is somebody had a history of trauma, and then the knot didn't go away, and lo and behold, they developed a cancer a few months later. Even within a few months, that sometimes can happen. So if you got something there and you had a history of a trauma, you can, within a year later and things, all of a sudden develop something. You do see that sometimes.
We're joined today by Dr. Richard Bush. Dr. Bush is an orthopedic surgeon with a subspecialty in orthopedic oncology. I'm just curious, Richard, I've known you a long time. What made you want to go to subspecialize in orthopedic oncology?
I went into orthopedics, and the only reason I went into orthopedics was because I had my knee blown out playing football, and I just got fascinated by how they reconstructed it, and then I decided to go into orthopedics. When I got into orthopedics, during the training, you went through histology and pathology, and I got enamored by that, and I almost became a pathologist. But then during my training, I discovered that there was a new realm of orthopedic oncology starting, and there was about 6 guys in the United States doing it back then. That tells you how I'm aging myself. And I went to New York, Chicago, California, and checked out the places, and I decided to go to Washington, D.C. at the NIH, and that's where I had my training, and the whole field of orthopedic oncology was still developing at that point in time, and that's how I got interested. So I got my fix from both pathology and orthopedics at the same time.
Do you ever work in areas with chemotherapy? Did you ever do work in chemotherapy as well?
Initially, we did. We had to get involved. But because the field has grown so much, and there's so much in the field that we have to know in specifics of techniques and training, that rarely does an orthopedic oncologist do anything with chemotherapy anymore, because it takes so much time and so much calculation, as you know, that I can sit there and I'm sitting at my desk talking to you, and I'm staring at 3 books that goes over one part of orthopedic oncology, and there's probably another 10 books that size that you have to stay up with and learn about just in my field. There's no way I can sit there and even pay attention to chemotherapy and agents anymore. It's impossible. That's why we have specialists like you to take care of that. I cannot deal with that. I don't have the time because I have to sit there and spend so much time continually staying on top of my field and learning techniques to help patients.
I see a lot when I'm dealing in medical oncology with infection. And a lot of our patients that become neutropenic sepsis and all. In your field of orthopedic oncology, you deal a lot in, like we were talking earlier, in kyphoplasty. Do you ever, is infection a difficult problem that you have in dealing in orthopedic oncology?
It is one of the most difficult things we have because you can do surgery, you can do things, but there's always that risk of infection. And the risk of a normal person that has no medical problems whatsoever and they have surgery, their risk is 1% or less of getting a soft tissue infection or infection. Anybody on chemotherapy and radiation and things, it's over 10 times. So it's 10% or higher that they can get an infection because of them, just because of the treatment. The problem is once you get that infection, your body now hasn't built up enough immune system to fight it and becomes very, very difficult to treat those things. So there's people that specialize in the treatment of that, and even in their hands it's difficult. And a lot of the people I treat are immunocompromised that had chemo or and then got infected, and it's very difficult to take care of them. But in this day and age, I can still save a lot of their limbs and a lot of their legs without amputation, where in the old days, as soon as someone with cancer got an infection, they right away got an amputation. We don't have to do that as often as we had to.
Richard, I want to thank you. Audience, this is Dr. Richard Bush. He is board-certified diplomat of the American Board of Orthopedic Surgeons. He is an office here in Plano, Texas. His office number is 469-443-0924. He is on staff at Centennial Medical Center, Medical City Dallas Hospital on Forest Lane, Medical Center of Plano, Pine Creek Dallas Medical Center, and I said Medical City Dallas Hospital. You are the medical director of orthopedics at Medical Center Plano. Is that correct, Richard?
Yes, in Dallas Medical Center.
Well, I want to thank you very much for joining us today. It's been a pleasure. I've worked with you for many years and always have a great deal of respect for you. You take care of my patients well, and I want to thank you for taking the time to answer the questions that I had. Is there anything else that you would like to add for the audience?
Yeah, I mean, what's important in this day and age, as Dr. Birnbaum says, is early detection. But at the same time, going to a specialist that's going to spend some time with you and explain what's going on. And unfortunately, in this day and age, that doesn't always happen. And the one thing that Dr. Birnbaum and his group is good at is really the patients just love when they go to him. He does such an excellent job in him and his group over the years, and that's why I still work with Dennis.
Richard, thank you a lot. Everybody, this has been Dr. Richard Bush joining us today. Richard, thank you for joining us, and have a nice weekend.
Okay. Thank you, sir.
You bet. This is Cancer Update, a short walk through a long journey. This is KAAM 770 on your dial. The phone number here is 972-445-0770. This is Breast Cancer Month. Please take the time to participate, to work with the communities. And we're going to take a short break, and we'll be right back. Again, this is Cancer Update, a short walk through a long journey.
Rosalind Slaughter is a very busy wife, mother, and teacher. She didn't have time for cancer.
After my first diagnosis, I had 2 lumpectomies, but the cancer had already spread. The doctor gave me little hope for recovery. That's when I called Texas Hematology Oncology for a second opinion. It had become stage 4 breast cancer.
The physicians and staff at Texas Hematology Oncology Centers aggressively attacked her cancer and were concerned about her quality of life during her treatment. Rosalind has been cancer-free for over 8 years now.
It really makes a difference who you choose for cancer treatment.
Rosalind and others have turned to the cancer treatment offered by Texas Hematology Oncology Centers. Perhaps you should too. Texas Hematology Oncology Centers has offices that are located in Dallas, Carrollton, and McKinney. To call for an appointment, please call 469-453-5500. That's 469-453-5500.
Good afternoon, everybody. We're in the end phase of our program this Friday. It's a little cool outside. Fortunately or unfortunately, the Cowboys are playing the Giants this weekend. I think we can almost predict the outcome. This is Cancer Update, a short walk through a long journey. The phone number here at KAAM is 972-445-0770. I have an article right in front of me here from Journal Watch, from the New England Journal of Medicine, that talks about the use of chemotherapy without surgery for metastatic colon cancer. The authors describe an important prospective trial of avoidance of primary tumor resection or surgery in metastatic colon cancer in an area where more effective systemic or IV chemotherapy. The findings support a role for the deferral of primary surgery when the primary tumor and its presentation are totally asymptomatic. This shows us that in many types of tumor, surgery is not necessary, that with the aid of chemotherapy, adequate chemotherapy, with or without radiation therapy, that good response rate. In this case, they use a protocol called FOLFOX, which is 5-FU oxaliplatinum with Avastin, and it was given every 2 weeks. And the response rate improved survival in a median follow-up at 20.4 months, where previously it had only been 15.2 months, showing you that now there are therapies out there that can avoid surgery if necessary. Another recent article that came out in dealing with ovarian cancer, and we talked about this a couple weeks ago, that the addition of Avastin given concurrently with high-dose chemotherapy elicited encouraging results in patients with metastatic ovarian cancer, along with systemic chemotherapy. So again, new things are out there for everybody to be aware of and to work with in their doctor and ask them about and going forward with their treatment. Also, a new recent article out of Integrative Medicine talking about the clinical evidence-based resource for complementary therapy, talks about exercise during and after cancer treatment. As of 2010, 14 million cancer survivors were living in the United States, with that number projected to increase to between 18 and 20 million by the year 2020. They were saying that all people diagnosed with cancer are considered cancer survivors for the rest of their life. It goes on to say that cancer survivors are highly motivated to seek information about lifestyle changes and things that will improve their lifestyle. And the main element that improved their lifestyle was the role of physical activity and physical therapy. During the time of chemotherapy, the rates of exercise declined considerably during chemotherapy and or radiation therapy. They were trying to counteract pain, fatigue, impaired cardiorespiratory capacity, reduced quality of life, and a suppressed immune system. The studies showed from the American College of Sports Medicine that exercise improved the immune system, improved the quality of life, improved their cardiorespiratory capacity and their tidal volume, or meaning their deep breathing volume, as well as reduce the amount of fatigue and pain that they had. We have discussed this previously, how exercise can do this. General physical activity, aerobic exercise, and resistance training have shown benefits and outcomes in cardiopulmonary fitness, muscle strength, body composition, and balance. Exercise has also been shown to improve quality of life, such as in fatigue, sleep deprivation, depression, and self-esteem. One of the things that I have seen over the years in dealing with patients, that age is not a criteria, that it does not matter what how we approach the patient. It is a patient and their family's determination as to whether or not they want to have treatment. But the one thing that you must consider, regardless of what type of treatment it is, surgery, chemotherapy, immunotherapy, or radiation therapy, is to put as part of your treatment regimen exercise. It will help your immune system, it will help your quality of life, and it will help your self-esteem. I want to thank everybody for being here. We're going to try and have another guest next weekend. This is Cancer Update, a short walk through a long journey. The number here is 972-445-0770. I want to thank again for our guest today, Dr. Richard Bush, orthopedic oncologist. Dr. Bush's phone number is 469-443-0924. His office is in Plano at 4001 West 15th Street, Suite 290, Plano, Texas. If you have a question in dealing with general orthopedic surgery, give Dr. Bush a call. If you have a concern of orthopedic oncology or cancer dealing with the bone or soft tissue cancer, give Dr. Bush a call. Again, his number is 469-443-0924. We're at the end of our program. Have a nice weekend. It's going to be cold. Bundle up, stay warm, and stay inside. Thank you all for listening. Tune in next week at 2 o'clock on Friday for Cancer Update, a short walk through a long journey. God bless y'all.
You've been listening to Ask the Pros, heard every Monday to Friday right here on 770 KAAM. Should you wish to speak with any of our experts, please call KAAM at 972-445-1700 and we will connect you with them immediately. Thank you for listening to Ask the Pros.
The views expressed in the preceding program were those of the speakers and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.